Good day, everyone. My name is Onowari Victor. I am a neurology aspirant, and I'll be doing the Chin Cheng's comprehensive review in clinical neurology. So we've done questions 1 to 17. We are about to do question 18 and 19. So let's begin. We have a 68-year-old woman with diabetes, hypertension, and hyperlipidemia who presents to your office with diplopia. Her extraocular motor examination is seen in figure 1.2. On popular examination, you note that her right pupil is dilated and non-reactive. Which of the following nerves is affected? Now, before we take a look at this picture, let us do a pretty basic investigation of our question. So they said her pupillary examination shows that her right pupil is dilated and non-reactive. Whenever I hear a dilated non-reactive um, pupil, I think, oh, do we have unopposed sympathetic activity, either due to the fact that there is a lack of parasympathetic innervation or there is something that is causing her sympathetic activities to be on overdrive. Remember that sympathetic activities will cause dilated pupils and parasympathetic activities will cause a constricted pupil. So that means that it's either your parasympathetic have been knocked off, causing unopposed sympathetic, or you have an agent that is causing the pupils to dilate. So let me give you an example. If you have cocaine, cocaine is actually a norepinephrine reuptake inhibitor, and that will cause a lot of norepinephrine to accumulate in the neuromuscular junction, and that can cause dilation. At the same time, if you have no parasympathetic activity to the eye, then you're going to have unopposed sympathetic activity, and that can lead to dilation of the eye. So that's in our mind. Let's look at the picture. So we have A, B, C, and D. So A is actually her looking forward in the primary gaze. Now, when she's looking forward unassisted in the primary gaze, her left eye seems okay, but the right eye has a significant ptosis. So you can see the significant ptosis. She can't even open that eyelid. Remember that the upper eyelid, for it to open, there are three muscles that are involved. The first is the orbicularis oculi, which is innervated by the facial nerve. The second is the levator palpebrae superioris, which is innervated by the parasympathetic fibers from the oculomotor nerve. And the third is the the molar muscle, which is from the underbelly of the levator palpebrae superioris, and that is innervated by sympathetic fibers. Um, so that being said, we have this patient who has ptosis. So we have ptosis already, and we have meiosis. Yeah. So sorry, we have ptosis and we have mydriasis, and that basically tells me that something is ongoing with the parasympathetic fibers. So let's keep on going. So for B, that's picture B. This patient had assistance and someone is trying to lift the eyelid up. But take a look, the patient is still in the primary gaze, and that patient's right eye is laterally displaced. So even though she's looking at us in the primary gaze, the right eye is still displaced. And what does this tell us? This tells us that she has weakness in her extraocular muscle. So, if we are to take a quick guess, we can see that this patient is looking more to the right. So, our lateral rectus is working. Yeah, remember, lateral rectus is controlled um, by the sixth nerve. Yeah, so her sixth nerve is working. So, let's look at the option C. This patient is looking down. So when they ask the patient to look down, this patient's left eye can look down, the right eye cannot look down, right? And then when you ask the patient on D to look to the left, this patient cannot look to the left. This patient's eyes are still fixed. That's the patient's left eye can move to the left, but the patient's right eye is still fixed. So the medial rectus on the right is gone. The inferior rectus on the right is gone. So this is actually just pointing towards the oculomotor nerve lesion. Remember, lateral rectus is controlled by cranial nerve number 6. Superior oblique is controlled by cranial nerve number 4. And the others are controlled by cranial nerve number 3, which is the oculomotor nerve. So this is looking so much like an oculomotor nerve lesion. So why oculomotor nerve? So remember that the oculomotor nerve actually has a parasympathetic fiber outside, and then it has the somatic fibers at the center. So that means that if you have a lesion that damages both the central and the peripheral aspects, you're going to get issues with the parasympathetics, leading to the mydriasis, leading to the ptosis because of affectation of the parasympathetic fibers that innervates the uh, ciliary body. At the same time, the sphincters of the pupil that causes dilation. Then also you have the ptosis because of the fact that there is lack of innervation of the levator palpebral superioris. Then we have issues with, with moving the eyes in some direction of gaze because of the fact that a good number of the extraocular muscles are damaged. So I would go with options A, which is right oculomotor nerve damage. In question 19, which of the following will be the least likely cause of the patient's finding? A says aneurysm of the basilar tip, B says aneurysm of the PCA, the posterior cerebral artery, C says aneurysm of the superior cerebellar artery, D says aneurysm of the pica, and E says aneurysm of the posterior communicating artery. Now, this, if I'm just taking a random guess, this will be options D, because D is really far down from A, B, C, and E, and I think it's best to look at the circle of Willis. But it's actually good for you to understand the anatomy of the oculomotor nerves. Okay, so let us discuss the anatomy of the oculomotor nerve. Now, the oculomotor nerve actually exits the brain stem at the level of the midbrain, in particular from the superior colliculus. It enters the subarachnoid space and it actually passes in between the posterior cerebral artery and the superior cerebellar arteries at the level of the basilar tip. And this is actually a very close proximity with the posterior communicating artery as well as the concourse of the temporal lobe. So if you have an aneurysm of any of these arteries, be it the posterior cerebral artery, the superior cerebellar artery, or even the PCOM, that's the posterior cerebral communicating artery, you may have a compressive lesion of the oculomotor nerve. Now, uncal herniation is a classical cause of third nerve palsy, although these patients are usually comatose. So that being said, let's go back to our question. Which of the following the least likely cause of the patient's finding? So we've already said aneurysm of the basilar tip should cause third nerve palsy. Aneurysm of PCA should. Aneurysm of SCA should. So pica will not. And aneurysm of PCOM should. So option D is the answer.